everyone. I'm Dr. BALA and I will be presenting a case report on bilateral posterior scleritis due to idiopathic cause. I have no financial disclosure or conflict of interest to reveal. As we all know, bilateral posterior scleritis is a rare but potentially vision-threatening condition which is often underdiagnosed due to its varied clinical presentation. It is painful inflammation of sclera posterior, 2 ora serrata, seen in all age groups and found in all ethnicities. The causative factors may vary and include idiopathic, infectious, non-infectious, and traumatic causes. The non-infectious causes is associated mostly with systemic conditions like rheumatic diseases in about 10% of the cases, and half of which are associated with systemic signs also. It's a female preponderant disease and it is mostly uniocular in presentation. It is sometimes also accompanied with the invasion of the optic nerve and therefore must be differentiated from the diseases like infection, retinitis, sarcoidosis, choroidal tumors, Beckett's disease, and Vigay syndrome. My patient is 56 years old male who is school teacher by profession, came to us on 25th August 2021. He had severe painful diminution of vision in both the eyes for last 1 week. The pain was deep and dull in nature, which was radiating to forehead and jaw, and it was waking the patient from sleep. There were also a few episodes of vomiting, but no past history of trauma, floaters, or flashes of light. He had no significant past history of any other diseases, and his family history was also non-significant. He was treated outside for conjunctivitis for last 1 week. When it did not resolve, he came to us. Regarding general examination, all the parameters were found to be negative. The only thing that we found that he was a cigarette smoker for the last 15 years. Regarding the ocular examination, the aided visual acuity was 6/36 in right eye and 6/18 in left eye. The ocular movement was same painful, restriction of movement was there in both the eyes. The leads were edemacious in the right eye. Conjunctiva were congested in both the eyes. The lens were found to be cataractus of NS grade 1 in both the eyes. The IOP was 18 and 12 mm of mercury respectively in the right and the left eye, and the angles were widely open in gonioscopy. On fundus examination, though the media were clear in both the eyes, there was a swelling of optic disc found in both, and the macula was edemacious in both the eyes with choroidal effusions in the right eye. These are the pictures on presentation. The anterior segment pictures after he was being pharmacologically dilated and the fundus photography. His CT scan picture, though could not be included here, it also showed scleral enhancement with thickening. This was the USG picture of right eye, which showed T signs. Left eye USG picture did not show any positive findings like T signs. And this is the autofluorescence picture of right eye. Various investigations were done as to find any systemic disease or cause of this inflammatory or any other inflammatory diseases, but they were not found, and therefore we came to the diagnosis that he was having an idiopathic bilateral posterior scleritis. Therefore, we started his treatment on oral methylprednisolone with the dosage of 1.5 milligram per kg per day, and it was tapered over 6 weeks, along with topical NSAIDs and systemic NSAIDs. The patient's symptoms resolved after when he came up after follow-up about 1 month. His patient's symptoms resolved drastically and his vision improved to 6/18 right eye and 6/9 left eye. These were the fundus photographs following the dose of methylprednisolone taken on various days during this follow-up. Therefore, we can conclude that this is a rare inflammatory disease of the sclera, which is most often escorted by immunological diseases like RA, vaginal granulomatosis, etc. But bilateral posterior scleritis is most often, it is idiopathic in nature, although some studies there are some studies which can associate it with the diseases like tuberculosis. A thorough examination is needed in posterior scleritis patient because it is often misdiagnosed as other diseases, and if the treatment can be started early, then due to the vision, the outcome are quite excellent. These are my references. My acknowledgements. Thank you.
Posterior scleritis is usually unilateral.
Yes, sir.
Usually unilateral, and the FFA is quite characteristic. There is a diffuse
Yes.
fluorescence pattern. Instead of pulling up the dye, all the nodular lesions will be homogeneously fluorescent.
The only
And,
imaging you did was an ultrasound and an autofluorescence.
Yes, sir.
Why wasn't an FA done? Any specific reason for FA not
Sir,
being
actually,
done?
at that moment, no, sir. It was not available in our institution. That is one. Nothing else, and the patient could not afford it from outside.
So was T sign the only sign which you thought points towards posterior scleritis?
Yes, sir. And in the CT scan was done. The sternal enhancement was found.
But why you have started that oral methylprednisolone? Because the disc was in danger. It was hyperemic. Disc was at risk. So I think it was better that you have started IV methylprednisolone. And then you will have to put your patient on oral steroids.
Did you rule out any other causes, neurological causes also?
No, sir. We did not find any neurological causes. As per the investigations which were done, the reason it was idiopathic in nature.
Did you do
it is very normal.
Could you find any systemic association in this patient?
No, sir. We did not find any systemic association. We did all the necessary investigations. We did not find it.
So what serology you have done?
Sir, we have done the P-ANCA, C-ANCA, everything we have done.
Which method did you use to do C-ANCA and P-ANCA?
Pardon, ma'am?
Which method? By which method have you done ANCA profiling?
Ma'am, that I cannot say because we sent it to the central blood bank located in our institution, Kolkata Medical Campus. So they did. We were not aware about the process of the
But
investigation.
henceforth, from an UVA perspective, you should know the test and the method of doing, because sometimes the sensitivity and the specificity that depends upon the test you do. So if you do an ANCA with immunofluorescence, it will give you a better sensitivity than you do with ELISA and all.
Yes, ma'am. We did not have that opportunity, but next time we'll definitely.